All right, Jordan, if you want to share your PowerPoint here, and then we can take over, and you have the floor, sir.
Sure. It says host disabled participant screen sharing.
All right, try it now, buddy.
Is that visible for everybody?
Looks good for me.
Okay. Are we ready to start, or do you want to?
Let's give it about 1 minute. I think some people are moving over from the previous one, and then 30 seconds or a minute, and then have at it.
All right. So I guess we'll start. So the topic today that I've chosen to talk about is over-the-counter overdoses. This is an incredibly broad topic. A lot of us deal with overdoses regularly as EMS providers in the field. Everything from opiates to methamphetamines to street drugs. But one of the most common medications overdosed in the country is not necessarily those illicit drugs. It's rather overdoses on over-the-counter medications. So there's probably 100 medications we could talk about today, but we're going to focus on 3 because I don't think we're going to have time to get through more. The format of what we're going to do is we're going to do a case study for each of the drugs, and then we'll kind of move through on how those drugs impact the body, and then we'll talk about the end of the case studies and if anybody has any questions. So we'll go ahead and start with a case study. The first case study we're going to do is, let's say you and your partner are dispatched to this residence. It doesn't look great from the outside. You could probably imagine what the inside looks like, but as you are dispatched to this call, you're dispatched for a psychiatric problem, which is also one of the most common calls that we go out for in the field. You arrive on scene and you find this male. He's probably in his mid to late 40s, going on 50. He doesn't look comfortable. He's obviously in a little bit of distress. His main complaint is dyspnea or shortness of breath, some lumbar pain, pain in the lower back along the flank, and nausea and vomiting, which, those complaints are very nonspecific at this point until we start moving further. He gives you a past medical history of hypertension, hyperlipidemia, diabetes, and HIV. What he tells you is that he took about 200 tablets of this medication today. And he took it maybe 3 to 4 hours ago. This medication, ibuprofen, is the first medication that we're going to talk about. Now, 200 tablets comes out to about 40,000 milligrams or 40 grams, which is a pretty substantial amount. Now, when I go out on an overdose and somebody tells me that they've taken 200 tablets of any kind of pill, I'm a little hesitant to believe them initially because it takes an awful lot of work to get that many pills down. I mean, you have to take handful by handful by handful, and you have to pound water. But if somebody is diligent and, convicted enough to try to hurt themselves, they'll do that. So this gentleman says that he took that many medications. And if you want to take a look at this, this is the general assessment that we've gotten so far. So he's consular oriented. He's restless and agitated, which kind of comes with the territory in a behavioral health crisis. You don't see anything horrible. He's tachypnic with some mild accessory muscle use, and you listen to lung sounds, which we all know how important it is to listen to lung sounds. You hear some rales bilaterally in the lower lobes. He's dry heaving, just stomach contents, no blood or tarry stools or anything. You find his pulse to be weak, slow, and regular, and there's nothing immediately concerning in his neurological state. So with that information given, you want to go ahead and get a set of vitals, right? So you have a heart rate of 54, which is a little low. His blood pressure is 172/96. Glucose is 104. Respiratory rate's about 26, which he's breathing fast. His O2 sat's on the lower end at 86. And you have an end-tidal CO2 of 22. Now this course I geared as much in between ALS and BLS as I could, so I'm going to throw some ALS numbers and stuff out there as well as BLS, but the general concept of these drugs is what's important. So we get an EKG, it's slow. It doesn't look great, but it doesn't look terrible. His waveform end-tidal CO2 is pretty adequate. You see a good plateau there. And we'll talk about these numbers here as we move through the medication itself. So when we talk about ibuprofen, we'll get back to that case study. It's one of the most commonly used and prescribed medications in the world. It accounts for about 9% of overdoses in teenagers. It's 29%. It's one of the most commonly prescribed medications in the US. And the usual prescription or recommended dosage in the bottle is about 200 on the very high end of 800 milligrams at a time. The onset of action, which when you take the medication, how long it's going to take to work is about 15 to 30 minutes after ingestion. I struggled a little hard on whether or not I wanted to incorporate how much of these drugs it takes to hurt you. But I think it's important for us all to recognize when we talk about dosages and how much it takes to reach a toxicological level. I think it's important. So when we talk about NSAIDs, ibuprofen specifically, one of the toxic effects can be seen at about 400 milligrams per kilogram. So that's a pretty decent amount of ibuprofen. And as we talked about, this patient took about 200 tablets, and he's at about 40,000 milligrams. So he's way over the threshold of a toxic event occurring. So let's talk about what NSAIDs do to the body, and then we'll talk about, what happens when you take too many. So when you have a trigger that's painful or inflammatory triggers, we're not going to so much get into the antipyretic or the fever fixing nature of the drug, but we'll talk about a painful response. So you have a painful response that occurs, and the body releases this enzyme called arachidonic acid. It's a polysaturated omega fat. Anytime you have an injury, whether it be localized or a massive traumatic event, you have the body that releases this acid called arachidonic acid. What that does is it triggers these things called cyclooxygenase. Now, some of this stuff is way above a basic and intermediate level of learning, but I think it's important to understand really what happens here. So you have this cyclooxygenase that is triggered. It's an enzyme, an isozyme, and what that does is it then causes a release of something called prostaglandins. Now, prostaglandins, they're a chemical or a compound that's released throughout the body in this slew of events. And when you talk about prostaglandins being released, they do different things in the body. So when we talk about that cyclooxygenase, you see this COX-1 and COX-2 at the top of the screen, and the circles that kind of coincide with them. COX-1 and COX-2 are these enzyme receptors, and in each circle, in the blue and the red, you'll see that they do different things. So when you have a triggering of COX-1, you get this gastric mucus production, which is extra mucus produced in the stomach. You get a release of bicarbonate in the stomach, and it's also controlling these. So it's a homeostasis event. And then you have platelet activation. So platelets are the clotting portions in the blood. And then under COX-2, you get this platelet inhibition. So depending on whether COX-1 or COX-2 is activated, you get different effects. At the bottom, you see aspirin and Celebrex. Those two medications are specific to COX-1 and COX-2. So when you take aspirin, it inhibits platelet activation, it inhibits gastric bicarb and mucus. And then when you talk about Celebrex, it causes platelet activation. When you talk about ibuprofen, naproxen, and diclofenac, and you see the purple in the middle, those are non-specific drugs. So COX-1 and COX-2 also act on renal perfusion, pain, and fever and inflammation, but the medications ibuprofen, naproxen, and diclofenac are non-specific. So they kind of act on a little bit of everything. When you talk about prostaglandins being released and you talk about cyclooxygenase, on a healthy patient, you get this renal perfusion. So you have good perfusion of the kidneys. You have a pain response. So when you have triggered this slew of events from the hammer to the arachidonic acid to the cyclooxygenase, it releases prostaglandins that cause pain. And we want painful response because it tells our body that there is an injury. You want a fever because a fever is a regulatory effect of the body to infection, just like inflammation is a good thing that can occur. When we take these medications, ibuprofen, naproxen, diclofenac, Celebrex, and aspirin, they inhibit the response of those proteins. So if you take ibuprofen, it's going to inhibit pain, it's going to inhibit fever, and it's going to inhibit inflammation. But what it also can do is inhibit renal perfusion. Now, at normal and lower levels of medication being taken, you're doing the right thing by inhibiting these processes. But if you overdose on the drugs is where you start to get into trouble. If you take an astronomical amount, you start to get this neurological toxicity, you get renal impairment, and you get metabolic acidosis. So when you take 4 grams or 40,000 milligrams of ibuprofen, what happens is your kidneys can start to shut down. You start to get neurotoxicity where you'll get delirium and you'll get agitation, and you get to see end effects like metabolic acidosis, where you're going to start to see their end-tidal CO2 drop in the field. Maybe you're going to start to see tachycardia, hypertension, which switches to hypotension. So you start to get these horrible events that happens if you take too many of the ibuprofen. Now in the field, we're limited on what we can do. The most important thing that we can do is recognize that the patient's taken these medications, and we can start to do supportive care. Now, fluids isn't a terrible thing. For these patients, we want to make sure they're oxygenated. Depending on how poor of a situation they get into from a metabolic standpoint, maybe you can start to play with sodium bicarbonate. That's obviously a command call. The thing about ibuprofen is it takes a little bit of time to start to do damage. Now, when we talked about an onset of action between 15 and 30 minutes, that would be for a regular consumption. If you're overdosing, it's going to take longer for the effects of that drug to impact the body. The nice thing about ibuprofen and NSAIDs specifically is that they're metabolized and excreted through the renal system. Some other medications go through the liver, but these medications primarily go through the kidneys, which is another reason why there's such a huge, profound impact on the kidneys when you overdose on them. The other thing that you can get when you overdose on these, when we talked about mucus production in the gut and acidity in the gut and bicarb in the gut, is that you start to get these peptic ulcers. So when people take too many NSAIDs, the first initial issue is that you start to get gastrointestinal problems. But when we take way too many, that's when you start to get renal impairment and you start to get some neurological toxicity. This patient that we talked about at the beginning, I threw some labs up there. We don't need to go into the labs real hard. We're not going to have a lot of time to go into the labs real hard. But if you look at the potassium is super high, and that's kind of a byproduct and related to the metabolic acidosis. The creatinine level, urea, those are related to the kidney failure. Those are kidney labs primarily, and those are astronomically high. And then you look at the pH. Now, if anybody knows anything about pH, when you talk about a normal pH of 7.35 to 7.45, 7.01 pH in the blood, you're looking at a almost non-life sustainable event. And with all of those together, this patient very easily could die. But these are actual case studies that I got off of the internet. This patient was hospitalized for 2 weeks. He was discharged to home with hemodialysis for 2 months. So because of the impact it had on his kidneys, he had to go through dialysis for 2 months. Now, 2 months isn't a very long time to be on dialysis. The reason for that is when you overdose on ibuprofen, since it is metabolized faster than the other overdoses we're going to talk about, it goes through the system easier. And as soon as the kidneys are perfused through hemodialysis, you can have a pretty decent recovery. He eventually regained kidney function, and the hospital lost him from follow-up, which is something that would not be uncommon to be heard of in a psychiatric event, or patients that are depressed that go through the health system. A lot of times overdoses, we take him into the hospital and then they just kind of peace out right after we get there. Luckily, he stayed long enough to get some hemodialysis and the appropriate care he needed. So the next drug we're going to talk about, does anybody have any questions about NSAIDs? I know I went really fast there. If not, that's okay. So our next case study, we are dispatched to a suburban environment, to this nice house. Pretty jealous, would love to live in a house like that. But when you arrive on scene, you're told you're there for another psychiatric event. You're introduced to a 17-year-old female who mom said she has been depressed the past couple of days. She hasn't really left bed. She skipped school once or twice. Mom came home from a night shift and found her lying in bed with a note next to her that said, "I want to kill myself." The patient's primary complaint is shortness of breath. I have lumbar pain. I didn't change the slide. That's my bad. But it's right upper quadrant abdominal pain is her primary complaint. So we'll just forget about the lumbar pain. Past medical history includes depression, anxiety, and ADHD. And she tells you that she took this medication. Now, this is Tylenol. And when we talk about Tylenol, it's a brand name for acetaminophen. Acetaminophen is the primary compound drug we're going to talk about now. Now, she took 80 tabs 3 to 4 days ago, is what she's saying, as she's been depressed throughout the week. And she took these 3 to 4 days ago, trying to hurt herself, and she tells you, well, nothing happened bad, so I didn't tell anybody, and I just kind of let it go. Well, 80 tabs of 500 milligrams of acetaminophen comes out to 40 grams or 4,000 milligrams. That's an astronomical amount of Tylenol. Now, that is identical to the amount that the gentleman previously took on NSAIDs, but Tylenol is going to have a little bit of a more detrimental effect to the body. And as you saw, he was more immediately affected by the NSAIDs. This Tylenol has taken quite a good bit of time to affect the patient. So when you start to do an assessment, the first thing that I notice is her eyes and her face and her skin. And you'll notice that it is yellow, and that means jaundice. Now, most of us know that jaundice is a reflection of liver damage, but we'll get into that. So her mental state, she's conscious, mostly alert. She occasionally dozes off. She's oriented mostly, but she's also disoriented to time, day, and some other questioning. So, one is our timeline of when she took this medication. Is it accurate? other than the jaundiced skin, you don't really notice anything crazy. She's got some nausea, vomiting, right upper quadrant tenderness. Her pulses are normal. So right now, nothing's super alarming other than some lethargy, maybe a little bit of confusion, and the yellow skin, obviously. So you get a set of vital signs. These are not awful. You'll notice the blood glucose is a little bit on the lower side. Blood pressure is pretty good for her age and size. Heart rate's normal. She's breathing a little fast. Her end-tidal CO2 is quite low. You'll see the waveform's appropriate. She's tachycardic on the monitor. So she's right on the precipice of whether we're concerned about inadequate vital signs versus adequate vital signs, but the primary concern is her skin and the fact that she took that many Tylenol. So let's talk about Tylenol. I thought this was really interesting. It's the second most common cause of liver transplant worldwide. And in the United States, it's the most common cause of liver transplant, overdosing on Tylenol. The recommended dosage for adults is 650 to 1,000 milligrams every 4 to 6 hours, not to exceed 4 grams a day. Toxicology develops after 7 to 10 grams a day or 140 milligrams per kilogram. So when we talked about NSAIDs, he took a pretty astronomical amount to cause what happened to him. When we compare NSAIDs with Tylenol, say for a 160-pound adult, it takes about 145 tablets of ibuprofen at 200 milligrams to cause a toxic event. For Tylenol, it only takes a few extra. So when you talk about a 160-pound patient at a toxic event of 140 milligrams per kilogram, it really only takes like 1,180 milligrams to begin to cause some liver problems. Now, if you do that one day here and then one day there and one day here and one day there, it's not going to cause a huge issue. But when you start to encroach that 7 grams per day for several days, it is really bad. So let's talk about Tylenol. We already talked about this cyclooxygenase 1 and cyclooxygenase 2 and how they affect the renal perfusion, pain, fever, inflammation because of the prostaglandin release. When you take Tylenol, it's very similar to those drugs, but it affects a little bit differently, and it affects something called cyclooxygenase 3. Now, for a long time, it was considered to be a COX-2 inhibitor, but now a lot of people think it's a COX-3 inhibitor. And when you take NSAIDs are primarily metabolized and excreted through the renal system. Tylenol is metabolized and excreted through the liver. So 5% of Tylenol is excreted through the renal system, but the rest of it does go through the liver. And when we talk about the liver, we don't need to get too far into this stuff, but 35 to 45% when you take Tylenol at a healthy, normal dose. So you take 500 at a time, or you take 650 at a time. The normal process of metabolism of Tylenol goes through 2 different processes called sulfation and glucuronidation. I'm terrible with that word. But when you talk about excretion through the liver, 5 to 10% goes through this cytochrome P450. So these 3 processes, when you take Tylenol, it's excreted appropriately. And that comes out to about 100%. So there's a little bit left when you're metabolizing that this byproduct called NABPQI, N-A-P-Q-I, is released. Now, NABPQI is a protein that's released through the byproduct of Tylenol through the liver, and this other system in the liver and process called glutathione cancels it out. It gets rid of NABPQI, and it is excreted through the liver ducts, and it's out of the body, and you're good to go. But when you take too much Tylenol, you take an astronomical amount of Tylenol, what happens is those glutathione receptors can't compensate for it. And you have this buildup of this protein called NABPQI. And when you get a huge buildup of NABPQI, that's when you start to see liver failure. So when you overdose on Tylenol, it happens in 4 stages. I know that was a lot, and I think it's important to understand that the primary issue when you take Tylenol is it's excreted through the liver as opposed to NSAIDs that's excreted through the kidneys. But when you overdose on Tylenol, say you take just a couple extra, up to that or over that 7 grams per day, you have a 4-stage presentation of what occurs. And when you take too much, the 0 to 24-hour marker, you talk about nonspecific symptoms. So say I took Tylenol 6 hours ago on an overdose. All I'm really going to show is some nausea, vomiting, and maybe some weakness. Nothing crazy, which is why this patient we talked about previously, when she overdosed on the Tylenol, she said, nothing happened. I kind of let it go. I thought I was fine, and I moved on with my day. Well, the issue is the damage is done. Stage 2 is 24 to 48 hours later when you start to get hepatotoxicity or damage to the liver, which is when you start to complain of right upper quadrant pain, which is where the liver sits. Transaminitis is a term for elevated liver enzymes. So the liver enzymes will start to elevate. But if this patient goes to the hospital and they do blood work, one of the first things they're going to do is say, I'm going to get a Tylenol level. Well, that Tylenol level is going to show as low or virtually non-existent in that 24 to 48 hour process. The reason for that is when we talked about NSAIDs are excreted almost immediately in the body, Tylenol is excreted very slowly. So as you're slowly metabolizing Tylenol, you're going to get much lower levels on a chemistry set than you are going to be with any other drug. So the issue then is if they do lab work, they see low Tylenol levels, they're going to say, a physician or a critical care team is going to say, well, I'm not worried. We'll just kind of monitor for a while and they won't aggressively start treatment. Treatment for this should be initiated immediately because you're not going to get the right labs. Stage 3 is a 72 to 96 hour mark, and that's when you start to talk about maximum liver failure. The LFTs or the liver enzymes are going to be through the roof. You start to develop this coagulopathy. And when I talked about Tylenol initially being thought to be a COX-2 rather than COX-3 inhibitor, you start to talk about platelet activation. So that patient's going to superclot. And with superclotting and liver failure, you're going to see a whole host of issues. You start to talk about neurological problems because of that clotting, which can lead to strokes. You also talk about hepatic encephalopathy, which is neurological events because of the liver failure, not necessarily because of this coagulopathy. But this patient now at 72 to 96 hours is in a really grave state. And then finally, 4 to 2 weeks afterwards, they're either going to recover or they're not. You're going to get that full recovery from the hospital once the body's finally metabolized the Tylenol, or you're going to get fulminant hepatic failure and they're going to need liver transplant. And at that point, there's not really treatment other than supportive care and liver transplant. When we talk about pre-hospital care for Tylenol overdoses, there's not a ton we can do other than supportive care. I threw activated charcoal in here. I know it was taken off of a lot of the trucks. We don't have it on the trucks at Warwick anymore, and the state's not super fond of it. But when this patient goes to the hospital, if they can get activated charcoal into the patient within an hour, that can have a profound impact on the end care of the patient, because that activated charcoal will help with the metabolism and excretion of the drug prior to it going through the liver. But that can really only be started within an hour process. So if you get to the patient, they say, I took, 80 Tylenol, I would say, instead of standing there and getting a whole bunch of history and a whole bunch of conversation with family and the patient, I would say, let's go right now. Let's go to the hospital. Because when we talk about time markers within that 1 hour, the other drug and the only antidote for Tylenol overdose that the hospital carries is called N-acetylcysteine or Mucomyst, and that has to be started within 4 to 6 hours for it to be effective. So this patient who we talked about earlier, who took it 3 to 4 days ago, is now way past that point of 4 to 6 hours. Had she called right away after she took the medication, there would be a pretty decent chance that she could get that Mucomyst on board and start to reverse the process. But now we're at the point where we're days out, we're in stage 3 of the Tylenol overdose. And when she went to the hospital, this was the end result of her care from per the case study that I found. So her AST and ALT, those are the two liver enzymes that you get. These are remarkably high. I mean, you see the normal is 4 to 48, and an AST, hers was 5,409. So her liver is not great. INR, what INR is the clotting factor, or the one of the measurements of clotting factor in the body. And the time for her is 5.1. So her clotting is not great. She has this coagulopathy going on. A normal time limit is less than 1 second. So she was promptly treated with NAC. They still started the process, even though it was 3 to 4 days out, just to give it a shot. I don't, I'm not a physician, so I don't know how that goes as far as their judgment on that. But she ended up developing fulminant hepatic failure, so her liver gave out on her. She was sent for liver transplant. Her LFT is approved by day 12, so her enzymes did come up, and she was eventually discharged after 25 days. So she was lucky and she survived. But when we talk about Tylenol overdose, if you don't get that prompt treatment, it's not going to end well. So recognizing what drug the patient took and getting to the hospital promptly is what's most important. Does anybody have any questions about Tylenol? Very well. So we have one final case study, and you're dispatched to this row home, kind of a urban suburban environment, for a uncooperative male. And the male's 17 years old, and police are dispatched with you. They arrive on scene just before you. They've kind of assessed that the scene is relatively safe. And I guess I should have mentioned before, as we all know, scene safety is the most important thing. But this patient, when you arrive on scene, you walk in the front door of the house, and this is what you see. The whole living room is kind of trashed. It doesn't look like it was trashed before. It looks like somebody went haywire. Mom is there. Mom tells you that her son was hanging out with his friends a couple hours ago. His friends left, and then shortly after that, he went berserk. He destroyed the living room. He was acting out. He appeared as though he was hallucinating. So those are the primary complaints. Mom tells you that he has no history. He's a pretty healthy teen. He has no history of depression, no history of anxiety, no history of drug use that she's aware of. But, when mom or dad tell you that their teenager has no history of drug use, you have to take that with a grain of salt because, for reasons. When you talk to a friend of the patient who still kind of lingered around on scene, he tells you that the patient was doing something called the Benadryl TikTok challenge. Now, this is going on right now. It's been going on for the better part of a year. It's not, it's been in the news, and I just thought this was a good example of why we should talk about Benadryl. But this TikTok challenge with Benadryl is these teens are taking substantial amounts of Benadryl to develop hallucinations, and they're posting it on the internet. Now, there's all these challenges that go on. We've heard about Four Locos and saturating certain things in Four Locos and sticking them places, and you talk about these challenges. But when you talk about Benadryl and overdosing on Benadryl, his friend tells you that he's taken 25 tablets of Benadryl 3 to 4 hours ago. So that comes out to 650 milligrams of Benadryl. That's a lot of Benadryl. When we talk about pre-hospital care and giving Benadryl for allergies, and you take 25 to 50 milligrams and it makes you sleepy, why is this patient, instead of now being sleepy and virtually unconscious, he's now going berserk and destroying the living room and destroying the house? So at a healthy dose of Benadryl, you'll get those chilling and calming effects. And we'll talk about why, and we'll also talk about why when you take a substantial amount of Benadryl, the exact opposite happens. So you finally get a hold of the patient, you do an assessment. He's very agitated and uncooperative. He's obviously hallucinating. He's talking about people that are there and things that aren't there, and he's seeing and smelling things. His skin is bright red, it's very hot, and it's very dry. His pupils are very dilated. They're non-reactive. He's tachypnic. He's breathing very fast. His lungs are clear. And and his pulse is very rapid. When we get a set of vitals, we see a heart rate of 150, so his heart rate's up, his blood pressure's up, he's breathing fast, everything else kind of looks normal, but at this point in time, we're still trying to figure out why is this patient going berserk because he's taking so much Benadryl and he's not sleeping instead. So when we talk about Benadryl, it makes up 3.2% of overdoses in the US. It's not the most common cause of liver transplant in the US. Forget that. Agitation, confusion, and hallucinations in ECG manifest after 300 milligrams of ingestion. Delirium, psychosis, seizures, and coma and death manifest after 1,000 milligrams. So it still takes a fairly decent amount of Benadryl to cause issues, unlike the Tylenol. But when you take too much Benadryl, a certain cascade of events occur. So let's talk about what happens when you take Benadryl normally and what it's for. So what is Benadryl for? It's a antihistamine, right? It's diphenhydramine. There's a whole host of other kinds out there. And when we talk about histamine, histamine is found in all sorts of cells in the body. So you have histamine found in platelets, histamine found in eosinophils, basophils, but the primary cell in the body that we're going to talk about histamines being in is mast cells. And when it comes to allergies, mast cells are one of the big players. Histamine's released when you have trauma, histamine's released when you have pain, histamine's released when you have fever, histamine's released for a whole host of different things, but primarily what we're going to talk about is allergens and the release of histamine with an allergy. So histamine is created, or mast cells are created in the bone marrow, and they're found in between connective tissue and blood vessels. So you have mast cells everywhere in your body that you have connective tissue and blood cells, which is virtually everywhere in the body. And in those mast cells, you have little chemicals called histamine. And histamine is what we're going to talk about. So you have histamine. Histamine's released through a process called mast cell degranulation. And you have trauma, temperature, allergens. Those all can cause mast cell degranulation, which releases histamines from the mast cell. So let's talk about allergens. And we'll talk about pollen because you could talk about anything that causes an allergy, peanuts, shellfish, what have it. But we'll talk about pollen because it's one of the most common allergens that people experience. So when you breathe in pollen for the first time, different people are allergic to pollen for whatever reason. Usually it's a genetic predisposition, but when you inhale pollen for the first time, you have these cells in your body called B cells. They're lymphocytes. They're part of the immune system, which are not the same as mast cells. They'll come in a little bit later. So you have a B cell in the body, and the B cell look at the pollen and say, I don't like you. You're suspicious. I've investigated you and determined that I don't like you. So what that B cell is then going to do is it's going to create antibodies. They're these little upside down Ys. And these antibodies are now little fighters who've determined anytime there's pollen that comes into the system, we're gonna instead of listen to the B cell for the investigation, we're gonna say right away we don't like you. So these antibodies then attach to mast cells. So now you have a mast cell which have antibodies on them that are filled with histamines. And the next time, round 2, when that patient or person breathes in pollen in the respiratory tract, those mast cells with the antibodies on them are going to release histamine. Those antibodies are what's going to recognize that there's an allergen. They're going to say, I don't like the pollen, we're going to release the histamines. And those histamines are going to do a whole slew of things. And just as we talked about, we have these mast cells everywhere. They're in the respiratory tract, they're in the lungs, they're in the gut, they're in the connective tissue surrounding most of the organs, they're in the bloodstream, they're everywhere. So when you have a localized issue, say an injury, they're going to release histamines locally. But when you have an allergen, which you have now breathed in, it's going to be a much more global release of histamine. So when you have histamine receptors that are all over the body. And when those mast cells release histamine, the histamine receptors all over the body are going to do certain things. So you have histamine receptors in smooth muscle. So when you have a release of histamines, you're going to get that bronchoconstriction, gut constriction. So when you have an allergy and now there's a release of histamines, you're going to have issues breathing. You're going to have some abdominal pain. It's in the blood vessels. So when you have histamine receptors that are activated in the blood vessels, you're going to get massive vasodilation throughout the body, which is another reason why your blood pressure will drop and your heart rate will go up. When you have this massive vasodilation, you'll get edema, swelling in the legs, swelling in the arms. There's histamine receptors in the skin, which causes the blistering and classic clinical rash that we see. There's histamine receptors in the nerves, so you can get pain. That's why you get itchy, because of the histamine receptors in the nerves. And then there's histamine receptors in the brain. And when there's an activation of those histamine receptors in the brain, you'll get really alert. So you have a patient who has an allergic reaction, you're going to go out, they're going to be short of breath. They're going to have massive vasodilation. You're going to get a rash. They're going to be itchy, and they're going to be super anxious and alert. So that is the normal body response to histamine receptors. When we take a histamine receptor blocker, which would be an antihistamine like Benadryl. Benadryl affects histamine 1. And when we talk about histamine, there's histamine 1, histamine 2, histamine 3, histamine 4. The things on this slide are primarily histamine 1. Those other histamine receptors do different things when they're activated, but this is the primary thing we're going to talk about is Benadryl. And Benadryl is a histamine 1 receptor. So when you take Benadryl, it blocks all of these things. So what happens when you take Benadryl? It stops vasodilation. It causes vasoconstriction. It makes the rash go away. It makes the itching go away. It inhibits bronchoconstriction. It helps, and that's why you get sluggish and tired when you take Benadryl, because that alertness that's in the brain is now inhibited because of the Benadryl. It's blocking that. The issue that we have is when you take way too much Benadryl, and you would think you, like with alertness, you'd get super, super tired, and you would get horrible vasoconstriction, which can occur. But when you take way too much Benadryl, what happens is you get this it's called anticholinergic. Some of the medics might remember what that is from medic school. I don't know how much of that they touch in a basic course right now. But when you talk about an anticholinergic response, when you take a substantial amount of Benadryl, like diphenhydramine, Dimetapp, Dahist, Dramamine, you get this cascade of events called an anticholinergic response. So the first thing on the response is mad as a hatter. The patient will get very confused, very disoriented. They'll get anxious. They'll start to have hallucinations. And those are all things that patient we talked about first. He's destroyed the house. He's going mad as a hatter. Eventually, those can lead to seizures and coma, which does happen to this patient once he gets to the hospital. But the next thing you have is dry as a bone. So the patient will get very dry skin. They'll get very flushed skin, red as a beet, hot as a hair. They'll get hypothermic. Their temperature will go up. Blind as a bat, they'll get blurry vision, and full as a flask, they get this urinary retention. So when you take a substantial amount of Benadryl, you get this massive cholinergic response, and all of these things occur, which is all the things that we saw in that patient. When it comes to EMS and treatment of Benadryl overdoses, it really is just supportive care. Scene safety is paramount. Fluids is not a terrible thing to do, but realistically, there's not a whole lot we can do in the field other than supportive care. I threw activated charcoal in there. The issue with activated charcoal in these patients is, you don't want to give it to somebody who's confused. So I guess we could just go ahead and forget that. But there is no antidote in the hospital. Those patients kind of have to wait their stay out. They'll get labs, fluids, and then they just wait until the body's able to excrete the Benadryl through metabolism. This patient arrived that we talked about, the one that kind of went berserk, had some mild rhabdomyolysis or rhabdomyolysis, depending on how you want to say it. Noted to secondary repeat seizure activity. So when you have repeat seizures over and over, you get this body response to rhabdomyolysis. Potassiums will go up. The kidneys can be impacted. They'll end up getting, decent amounts of fluid, and then they have to mess with the acidity level in the body through maybe some sodium bicarbonate. But that's secondary to after treatment of seizures, and treatment of seizures in an EMS perspective is obviously supportive. The patient had several recurrent seizures in the ED. He was admitted to the hospital for 10 days workup and then discharged for behavioral health management. So that was a lot. That was 3 drugs, and I wrapped it up just about an hour. Does anybody have any questions about that? I guess the most important and primary thing to keep in mind is recognize what the patient overdosed. And out of the 3 of those drugs that we talked about, Tylenol is probably the most concerning as far as time management and getting them to the appropriate facility. And it really only takes a little bit of Tylenol. And the more underlying medical conditions that those patients have, the more at risk they are for the amount of drugs that they've taken. And that's all I have.
Thank you, Jordan.